everybody. My name is Monisha. I'm one of the PGY3. Today I'm going to be talking about a couple different procedures for my potpourri of procedures. Credit to Dr. Camacho for coming up with that name.
Yep.
Okay, thank you to the procedure day team, including Dr. Lamb, Dr. Arboyo, Dr. Camacho, Dr. Clark, Dr. Gennaro, and Dr. Kim for giving a lot of feedback and help on this lecture. So, what we're going to be talking about today. First, I'm going to go through the lateral canthotomy indications, how to do it, and things to look out for. Then a couple of different indications and how to use the ultrasound, and some takeaways to just kind of keep in mind when you're dealing with that eyes. So, starting with lateral canthotomy and inferior canthal, which is actually the full name of what we do for the lateral canthotomy. What do we use it for? First, acute orbital compartment syndrome, which is increased pressure due to some sort of external force and causing decreased visual acuity, increased intraocular pressure greater than 40 millimeters of mercury, as well as proptosis. I don't know if you can tell the picture of some of these eyes. What other indications would we use this for? Afferent pupillary defect, as you can see here, a cherry red macula, or ophthalmoplegia. If you see these on exam, these are things to consider for increased orbital compartment syndrome or increased intraocular pressure, and things that you might want to use to relieve the pressure of lateral canthotomy in this sort of situation. What can cause increased intraocular pressure? Trauma, causing retrobulbar hematoma, which I don't know if you can tell. Right over here, there's the hematoma likely labeled for us. For these, the incidence of actually having retrobulbar causing elevated intraocular pressure with trauma is quite low. The incidence is less than 1%, but if untreated, can lead to serious sequelae such as blindness. So if you decide that you're going to do a lot of procedure and something that you pull the trigger for really quickly, and you would do this based on increased intraocular pressure in the trauma pen. As well as assessment of visual acuity. Another is spontaneous bleeding. This is not a picture of actual spontaneous bleeding. This is a subconjunctival hemorrhage. Do not do it for subconjunctival hemorrhage, but I just couldn't find a better picture for eye bleeding because nothing comes up on Google, surprisingly enough. And then orbital cellulitis. Yes, okay, orbital cellulitis could also cause it, as well as tumors or masses, such as any kind of intraorbital tumor, uveal melanoma, retinoblastoma. You can also get it from systemic malignancies, such as leukemia. They can also cause increased intraocular pressure and can cause mets to the eye as well. That's a picture of the tumor. When don't use it? Globe rupture. Don't do anything with globe rupture. That at that point also there's no real increased intraocular pressure because the globe is ruptured. It has given its own outlet for the pressure. So things to make sure that you gather for lateral canthotomy: chlorhexidine or some sort of cleaning agent, lighter with epi for analgesia. Iris scissors, which are the tiny little scissors that can help you cut. Forceps, and a straight chemostat to clamp and kind of reduce bleeding. So for the procedure itself, first you're going to start by cleaning the area with chlorhexidine, make sure it's real clean. Then you're going to anesthetize the area. Make sure that when you are injecting, you start at the lateral canthus to the orbital, and you go towards the orbital rim away from the globe. You do not want to put anything sharp facing in towards the globe. Next, you're going to irrigate the eye with saline to try and move any debris that you can if there's any kind of foreign bodies or anything. Then you're going to slide a straight mosquito chemostat along the lateral canthus on the side with one prong against the orbit and the other superficial to the skin. So basically you're sandwiching the side with the lateral chemostat. Then you kind of compress down, and you want to compress this for about a minute. This is going to help reduce the amount of bleed that you have. In that same section on the orbital rim at the lateral canthus, after you control the bleeding, you're going to cut all the layers of tissue with the iris scissors. This is a scalpel, but the iris scissors are in this section. Then you grasp the lower lid of the eye with forceps, retract it to reveal the lateral canthal tendon, which is just inferior and posterior to the lateral canthal fold. I know this all sounds very confusing, but there's a video that demonstrates this very nicely as well. Then you're going to completely cut through the middle of the lateral canthal ligament with the iris scissors. Once you cut down on the lower eyelid, the lateral canthal ligament will be very obvious, and you'll just be able to cut through it. Then for the inferior canthal portion, you're going to pull down the lower eyelid a little bit further to expose the inferior crus of the lateral canthal tendon, and then you're going to cut the inferior crus right there. So after you're done, what do you want to make sure you do? You want to recheck the pressures in the eye to ensure lower pressure. If you do not lower the pressure sufficiently, you can consider superior crus canthalisis topic and completely cutting the lateral canthal tendon. You also want to keep an eye out for kind of fun rebleeding or new surgical site bleeding, especially if the patient has got any kind of anticoagulation, disrupt vision, disrupt field of view. And just bear in mind that opto obviously will need to be on board for all these because these patients will need to be ultimately repaired in the OR by the ophthalmologist. So what are some potential complications of this? Bear in mind that you're putting sharp things next to the eye. There is a risk of globe injury or structural injury, which you can minimize as much as possible by pointing all of the sharp things away from the eye. There's also a risk of bleeding. As much as you can minimize this with the light with epi, as well as using chemostat to crush the area to reduce the amount of bleeding. Also, risk of incomplete canthalisis, which we covered by cutting the inferior crus or cutting the superior crus for extra pressure relief. Also, risk of infection with any kind of procedure that we do. Again, chlorhexidine, make sure it's as clean as possible. And the last is, if not repaired in time in the OR or just in general, if you cut too many things, there is a risk of loss of adequate lower limb system. What do we want to watch out for? The biggest thing is don't delay surgical management or mostly lateral canthopathy. If you're concerned that this patient has some sort of increased intraocular pressure that can be relieved by this, it's a vision-saving procedure. So any delays, including while you're trying to call opto, while you're trying to talk to the healthcare proxy, all these image, sonal, all of these things can be very costly. So if possible, try to do these concurrently. Try to get opto on board as you're setting up the procedure, getting everything. And the other thing is you need to correctly identify increased intraocular pressure early. Oftentimes vision changes can be a late finding. So the other things that we discussed, cherry red macula, if you can see it, or ophthalmoplegia, something along those lines might present earlier. And especially if the intraocular pressure is greater than 40 millimeters of mercury, definitely keep this higher on your differential or higher on your list of things to do. There is a 3-part decision tool that one of the papers that I read discussed as a need to predict as a way to predict the need for lateral canthopathy and inferior canthalisis. That kind of follows with the relative proptosis, tight eyelids that are difficult to open with finger pressure, like you might see in orbital cellulitis, and the presence of a relative apparent pupillary defect in the traumatized eye. The next thing to kind of make sure and watch out for is making sure that you completed an effective amount of canthalisis by checking the intraocular pressure immediately after the procedure. If there's an inadequate reduction in the intraocular pressure, you consider a superior canthalisis like we talked about before. You could also consider some medical management, mannitol, acetazolamide, high-dose methylprednisolone. And the last thing is try to avoid iatrogenic injury as much as possible. You can use a Morgan lens, and that can help cover the eye itself, and that can prevent pointy things from pointing too close to the eye. Consider procedural sedation if the patient is either in a lot of pain, moving around a lot. This is something that can help reduce the risk of trauma to the eye, and make sure that as much as possible you are achieving ophthalmic analgesia to prevent the risks as well. And make sure that you're using antibiotics afterwards to prevent systemic infections and control bleeding as much as possible. These will all reduce the risk of iatrogenic injury. Next, for the ocular ultrasound. Indications of the ocular ultrasound. I realized just now that the procedure. Oh, this is the video I want to show. Let's do that now. Can you guys hear?
I'm Dr. Jeff Mason, and this video shows illustration and real lateral campus. That's a procedure to release an orbital department from the hemorrhagic pressure pushing on the eye. Usually that's from a retroculateral left. That's a pocket of blood pushing the eye forward. You want to create an incision, so basically let the eyeball come forward. You're only going to remember one number. I want you to remember 40. 40, that's 40. It's the intraocular pressure when you need to cut and ease the compartment. Let's go through the steps. First step is you want to get it numbed up. So lidocaine with epi, be a nice doctor. Second, you're going to crush the lateral canthus gland. This devascularizes the area. Yeah, here it is in the real procedure. You want to leave that clamp there for about 1 minute so it doesn't sting. Cut. Coming up, step 3. Cut the lateral canthus. You're going to cut towards the orbital rim on the side. Next, you're going to cut that lateral canthus ligament, which has the leads superior and inferior on the side. You want to cut down, cut that inferior. Sometimes there's enough pressure on its own, but if not, superior. It can be real hard to see for you, not just the patient. Blood, and stuff. So even if there was your instrument with tactile feedback, it sort of feels like a guitar string. Again, recheck your intraocular pressure to make sure it drops, and this is how it should look. Done.
All right. Okay, hopefully that was a little bit easier to see exactly what you do with all the steps there. So next for the ocular ultrasound, when might we do these? Increased intracranial pressure, when you're looking for vitreous hemorrhage. If you have a patient that's presenting with any vision changes, painful or painless, or if there's any kind of eye trauma, again, ocular rupture, or if the patient has any kind of floaters, splashes, things that you want to evaluate them for. Again, as we talked about, don't do this in globe rupture unless you're a very experienced sonographer and have a ton of gel and do a very, very light. So how exactly do you set the patient up for this? You keep the head of the bed at 45 degrees, a large tegaderm with both the eye, and have a ton of normal ultrasound gel with tegaderm. You're going to use your linear probe, minimal pressure, and take a look at the eye, both in the sagittal and the axial plane. To get your orientation, you can ask the patient to look up, down, left, right, whatever you need to kind of improve the view. And what you're aiming for is what you see over here on the right, where you see the globe, the anterior chamber, and you see the optic nerve and then the back right behind the retina area, which is going to be that hypo. You can also, if you want, as a comparison, image the contralateral eye, the normal eye, to if you're having difficulty differentiating from abnormal. A normal eye, as we talked about, is going to have your globe itself, the lens right here, anterior chamber. You're going to see your vitreous with the retina at the bottom and your optic nerve. You can initially start by adjusting the depth and reduce the gain until the vitreous is black and completely anechoic. If you have the patient move their eye from right to left, you're going to be able to help determine all the structures for yourself. It also helps you see a pretty clear image of any kind of retinal or vitreous abnormalities if they're not completely attached. Indications, just to go through some of the indications and the data for ocular ultrasound. The first is retinal detachment. It's seen in normal and often low gain settings. So that's a picture. I don't know if the brightness on here or on your screens at home is able to see that a little bit better. But basically, you're going to see that in normal low settings, you're going to see a thick cord that's attached to the back wall of the eye. And if you ask the patient to move their eye, you're going to see this cord moving and flapping. You're able to see it right there. If the retinal detachment is large, the flap will be attached to the optic nerve sheath. But if it's really small, you might have to look in several different axes to be able to see whether or not there is an adherent or non-adherent flap in the back. If you have a posterior vitreous detachment, which we'll see a little bit later, they're only loosely adherent and they're going to move freely with kinetic ecog, which is movement of the eye, asking the patient to move the eye while you have the sonograph on there. If an important thing to note, and especially for our opto colleagues, is whether or not it's attached to the back of the macula or the fovea. A MAC on, if it is attached, is more emergent because it has a better prognosis and vision can be spared if spared within 24 hours. So often these are going to be more likely to stay versus the MAC off, which has a little bit poorer prognosis and sometimes also will allow us to see the next day because it's less likely to help the vision in the next 24 hours. Bear in mind the presentations for retinal detachment, acute onset of unilateral floaters, pinpoint flashing lights, visual loss, visual field cuts, can be caused by trauma, but more commonly spontaneously or by systems such as this is from the Focus Atlas, looking at a prospective multi-center trial at 2 academic and 2 county ERs. They recruited people with symptoms of blurry vision, flashes, floaters, vision loss, and excluded ocular trauma. The results were shown to opto attendings who did not know about diagnosis and no finding. The retinal detachment, as you see, is quite sensitive and specific, with a 96.9% sensitivity and 88.1% specificity, and a strong likelihood ratio. The next is vitreous hemorrhage. As you can see here, you can see basically diffuse mobile opacities. You might for this one have to turn up the gain for the file, and you're going to look for kind of what looks like a snow globe type appearance. You can see this in diabetic patients or after a concurrent posterior vitreous detachment. Patients often have floaters or sudden painless visual loss, visual sort of haze, can be spontaneous or secondary to trauma. Even though it's not an ophthalmologic emergency, an ED sonographer, we should be able to recognize vitreous hemorrhages and ensure the lack of underlying posterior segment pathology. Dr. Schechter mentioned for the retinal detachment, we should not be deciding with MAC on or off. Either way, if you see the detachment, call off. For the vitreous hemorrhage itself, the data also shows, again, pretty sensitive to specific, less so than for retinal detachment, with 81.9% and 82.3 specificity. Again, things to make sure that this is more adjunct in focus, especially because something like this is not the sole thing you're using as a diagnostic measure. And that's with vitreous detachment. Basically, what you're looking for is a hyper-equilinear floating structure with increased echogenicity. If you're looking at it right here. Oh, thank you. Yes. Next. Okay. It's going to look similar to retinal detachment, but this one is not tethered to the optic disc. It's called sometimes a swaying seed appearance, and you would look for this in patients with, again, acute unilateral floaters, vision loss, visual field cuts. This one has a lower sensitivity with 42.5, but it's still 96% specific. So again, not to rule out completely, but if you do see it, it's quite specific. Another thing to use an ocular sono for is increased intracranial pressure. This can help determine also an adjunct if you have a suspicion for increased intracranial pressure in the short term to see even before you get into some sort of imaging. The reason we use this, are able to use this is because the optic nerve sheath communicates directly with the intracranial space. So an increased ICP is reflected by a dilation of the optic nerve and often with anterior bulging of the optic disc. The ocular ultrasound is used to measure the optic nerve sheath diameter, and you can also see that bulging on the sono itself here. The way you're going to do that is, remember the numbers 3 by 5. So you're going to measure 3 millimeters posterior to the globe, and less than 5 millimeters across is normal. 5 to 6 millimeters is indeterminate. Greater than 6 millimeters is elevated. Some more data for this. This was done in a systematic review of 12 studies, and they did an ultrasound measurement of the optic nerve diameter. What they found was, and they used the threshold 5 millimeters for adults. If you're looking at kids 1 to 17 years old, 4.5 millimeters, and then the threshold for less than a year-old, if you're able to get a sono on their eye and not have to go around, is 4 millimeters. For this, there's a really good negative likelihood ratio, so it's a good test to rule out increased ICP and low risk. And combined with the good positive likelihood ratio, you can use it in high risk to rule in. Again, make sure you keep in mind that the high risk patients having a normal doesn't mean that they don't have it, and for the low risk patients, if you see it, it's something that might merit further investigation. Gold standard that this is all used to compare to is the CT, oftentimes. And the last is the intraocular foreign body. This is something that if you're concerned and you can't see directly on the eye, or if you want to visualize exactly where it is, maybe for ophthalmology, you're going to take a look at the eye and you're going to look for something bright, echogenic, and either shadowing or reverberation, can't say the word, artifacts, usually in the vitreous itself. You can use, you can see any kind of shadowing or cocktails or whatever based on the structure of what exactly. So things to kind of keep in mind for our for all of these procedures. The one thing for the lateral campani inferior canthalitis, use the chemostat to crush the tissue to prevent bleeding. Don't do anything but a CT scan and call opto if you suspect globe rupture, unless you have very, very light touch or a really good sonography. An ocular ultrasound is a fast, easy way to perform for a number of differentials for all of your patients with unilateral painless flashes, floaters. And you can use the sono for elevated ICP to rule in high risk and rule out low risk. And that's all. Thank you guys. Dr. Schechter says, my personal opinion on measuring optic nerve sheath diameter is that it's a waste of time. Data is not fantastic, and the difference between 0.02 millimeters is minuscule. Thankfully, we have CT. Good point. True. All right.
Any questions?
Is there anything?
Awesome. Thanks, Alicia.
Cool.